So my talk is first-line systemic treatment for a urothelial cancer, end of the platinum era, because for the last decades, platinum-based chemotherapy has been the mainstay of treatment for urothelial cancer. And these are the data that actually until last year was still determining our first-line practice. So I think the main decision to make is your patient cisplatin eligible or ineligible. The standard treatment for patients who could receive it is cisplatin-based chemotherapy, where we generally see quite a reasonably high response rate, but also recurrence of usually a few months after treatment has ended, and then a small population of patients in the past who still had good clinical outcome, multi-year good clinical outcome. And when looking a bit closer at this population, we see that the location of metastases determines this long-term outcome with patients who have lymph node-only disease doing much better than patients with, for example, liver metastases, and patients, of course, with a good performance score doing better than patients with a PS of 1 or higher. So all of this changed last year, and this is the first trial that I will discuss. This is the EV302 trial, a trial of enfortumab vedotin, an antibody-drug conjugate which is directed at Nectin-4 on cancer cell membranes, together with coupled to an MMAE, so a microtubule inhibitor, vedotin. And this ADC had already shown a benefit in third line, so after chemotherapy and IO, in the third line setting, and is combined with pembrolizumab in this case, and especially this combination showed very high response rates in previously untreated patients. So this trial randomized patients with locally advanced or metastatic urothelial cancer who had not received any previous treatment in a metastatic setting. And these patients were all eligible for all study drugs and PD-L1 inhibitor naive, and received either the combination of enfortumab vedotin plus pembrolizumab, or EVP as I will call it. And this was with pembrolizumab for a maximum of 2 years, and EV as long as tolerated and until progression. And this was randomized versus platinum-based chemotherapy, where importantly the choice of platinum was made based on commonly used Galsky criteria. So the protocol basically mandated that you had to use cisplatin or carboplatin based on these criteria, and that it was not merely an investigator or patient decision. The primary endpoints were progression-free survival by central assessment and overall survival. So, and this trial met its first primary endpoint of progression-free survival, significantly improving PFS with a hazard ratio of 0.45 and a median progression-free survival in the EV plus pembrolizumab arm of 12.5 versus 6.3 months in the chemotherapy arm. And this was, of course, an incredible result. So if we look at this forest plot for progression-free survival, we see that there's basically no subgroup that did not show benefit on the progression-free survival analysis. So patients benefited from EVP regardless of, for example, PD-L1 expression, cisplatin eligibility status, the presence or absence of liver metastasis, and all these other clinical characteristics mentioned here. This treatment also significantly improved overall survival, the other primary endpoint of this trial, with a hazard ratio of 0.47, and again a highly significant p-value. So what we see here is that the median overall survival for the chemotherapy group was 16.1. For the EV plus pembrolizumab group, we see that there still may be some development in the Kaplan-Meier curve at the end with further follow-up. The follow-up of this trial at this analysis was only 17 months, and at this point, the median overall survival was 31.5 months, but this may develop further with further follow-up. When we look at the important subgroups, so cisplatin eligibility has dominated the choice of therapy for decades, and we see here that EVP improved overall survival regardless of cisplatin eligibility, and also regardless of PD-L1 positivity. So both in PD-L1 high and PD-L1 low patients, EVP clearly did better than chemotherapy with hazard ratios under 0.5. And for the groups of cisplatin ineligible and PD-L1 low patients, the median overall survival was not even reached. So then the presence or absence of liver metastases, or the group of lymph node only disease, which is at the other end of the spectrum, being the more favorable group. All of these groups showed an improvement in overall survival for EV plus pembrolizumab, with very strikingly similar hazard ratios under 0.5. And again, in this group, we see that the median overall survival in the group who does not have liver metastases or with lymph node only disease has not been reached. And for the lymph node only disease, at this point in the analysis, the overall survival seems to settle at 70%. So then safety, EV plus pembrolizumab is a very different treatment than chemotherapy, and there is for sure a learning curve in treating patients with enfortumab vedotin and also with the combination. For example, peripheral sensory neuropathy is a commonly occurring toxicity, which is often the reason for patients to eventually discontinue treatment. Skin reactions also occur quite often, usually of low grade, but sometimes this can be of high grade and occurring very rapidly. And then in those cases, it can sometimes be life-threatening. Another important toxicity to point out is hyperglycemia, which can occur sometimes very rapidly early in treatment and can also be life-threatening. One of the other important potentially life-threatening AEs, which is not on this list because it doesn't occur very often, is pulmonary disease, which also has led to grade 5 toxicity in the past in some patients. And I think although the grade 3-4 toxicity overall was not higher for EV pembrolizumab than for chemotherapy, which is also due to how fast you can get a grade 3 event for certain toxicities. It's much more skewed to chemotherapy-related toxicity. We also saw that treatment-related adverse events leading to death were equal in both arms, both under 1%.
So could you talk a little bit more about, sort of the clinical issues that come up with this combination, kind of the things you might go through with a new fellow in oncology? And I guess one of the issues is a lot of these side effects theoretically could be from either one of these drugs. I mean, you see rash with IO. We were talking about diabetic ketoacidosis before. So can you talk a little bit about how this plays out, what the timing is of these issues, and also the qualitative management and prevention of these problems? Also, do you look at hemoglobin A1C at all and trying to determine whether you even get started?
Yeah, so this is all very important questions. So the first thing I tell both my patients and the young doctors who are starting to treat these patients with this drug is that it has basically toxicity of EV has two phases. The most common phase is that of slowly accumulating toxicity. So you will see skin reactions or neuropathy, and it will slowly increase, and you have time to think about these toxicities and maybe dose reduce or ask the dermatologist, give some supportive care to try to mitigate these symptoms. And that's even though you have to get used to the symptoms, is the more easy to manage AEs. The really important thing is for both patients, especially for patients and for their caregivers, but also for the doctors treating these patients and for the nurses at the daycare unit, is that some toxicities may occur early, very early, and be really life-threatening. And the most important ones are skin reactions, hyperglycemia or metabolic disorders. We sometimes saw a sort of a metabolic acidosis syndrome, and pulmonary symptoms. And those, if that happens in your patients, even though it's not very severe at the beginning, if it happens early in treatment, I always instruct everybody to immediately to not give another dose of therapy, and first wait and see if this toxicity develops in something really life-threatening. Sometimes it turns out that it's just still a mild toxicity, but the last thing you would want to do is give another course of enfortumab vedotin when patients are developing these toxicity, because that's how patients really get into trouble. So indeed, potentially, it could be difficult to tell apart these two toxicities from both drugs. I think usually the treatment dynamics, or the dynamics under treatment, I must say, can tell you a lot. So if it happens really early, then it is a bit more likely to be EV related. If you pause treatment and it gets better, that's also more likely to be EV related. And if it gradually gets worse, it's more likely pembro related. But this can sometimes be difficult. And if you think that you have a severe IO toxicity, let's say a pneumonitis, you should just treat with steroids early and get it under control, and then see what the eventual conclusion is. I think one thing to add here is that in this combination we can be very focused on the EV related toxicity, because that's what will keep you busy mostly. But sometimes the danger could be here that you lose track of certain IO related adverse events that are more insidious, like for example adrenal insufficiency.
Just kind of curious overall, like what fraction of patients sort of cruise through, do not need any dose adjustment at all with this combination?
So I think everybody, given the time, will need some dose adjustments. So sometimes a dose delay or a dose reduction, and usually this starts to occur around cycle 4 to 8, more or less. The patient needs some adjustment to treatment. We also saw on the recent ESCO, a presentation of the third line trials with EV, but I think there's not much of a difference there, where we saw with pharmacodynamics and pharmacokinetics, and we saw from that presentation that actually reducing the dose at some point does not jeopardize efficacy, it seemed, in the long term.
So this may seem like an unusual question, but just kind of curious, if this trial had been 4 arms and the other 2 arms were single agent pembro, single agent EV, I'll just ask you about efficacy. Won't even ask about tolerability, but let's just say efficacy wise, what do you think you would have seen?
Yeah, that's a very good question. I think we did the trials with mono IO, of course, and those treatments were not able to beat chemotherapy, which also shows that chemotherapy has always been very difficult to beat. I think with EV and EV pembro, it's a bit more difficult. A trial has been done, cohort K of the EV 103 trial, I think, if I say this correctly. And in this trial was randomized between EV and EV pembro. The results were that there was a difference in response rate. So EV had a response rate of about 45%, whereas for EV pembro it was between 65 and 70%. So there is a difference. For PFS, there seemed to be a difference as well, but follow-up was not very long yet. For OS, I think the difference was still at that point difficult to say, but definitely in response rate and progression-free survival, there seemed to be difference between these treatments. And I think we have to keep in mind that it's been incredibly hard to beat chemotherapy, and bladder cancer is, especially advanced urothelial cancer, is a disease that we have to get under control soon, or we will lose the patients in follow-up lines of treatments.
All right, please continue.
So at the same ESMO last year, another trial was presented that actually showed data that chemotherapy could be beat. This is actually the first one that came out, read out, and showed an improvement to chemotherapy. This is the Checkmate 901 trial, in which nivolumab plus gemcis was compared to gemcis alone. So this was a trial only for cisplatin eligible patients. In previous trials with chemotherapy with or without IO, all patients, regardless of cisplatin eligibility, were allowed, and actually investigators also had the choice themselves of whether to administer cisplatin or carboplatin. And one of the hypotheses that came from a deeper analysis of these trials, that perhaps if it would have been restricted to cisplatin, the combination would be more effective, and the trials could have been positive. So that's exactly the hypothesis that was tested here, that cisplatin plus gemcitabine combines well with nivolumab. So again, patients with previously untreated, unresectable, or metastatic urothelial cancer who were cisplatin eligible and had good performance score were randomized to receive either cisgem standard 6 cycles or cisgem plus nivolumab, followed by nivolumab monotherapy. So both groups had about 300 patients. So again, the primary endpoints of this study were overall survival and progression-free survival. These were the results. So this trial met both of its primary endpoints, improving both overall survival with a hazard ratio of 0.78 and progression-free survival with a hazard ratio of 0.72. So for the progression-free survival, we can see that in the beginning, these curves really track together and start to separate after 6 months, and then remain apart, suggesting that that especially the more durable responses are making the difference here. So if you look at objective response rate for these two treatments, nivo plus gemcis did better than gemcis alone, with an overall objective response rate of almost 58%. And this was especially different when looking at complete remission, which was almost double in the nivo plus gemcis arm. I think strikingly, these responses were achieved early, but especially if we look at complete remissions, we not only see that they're more frequent, but they're especially more durable, with a median duration of complete remissions in the combination arm of 37 months versus 13 months in the gemcis arm. And I think this shows that this treatment combination can induce rapid, deep, and durable responses in a subset of patients.
I just realized by asking people if a trial had a different arm, what would it show? It's better than saying, how would you indirectly compare? So how about if EV302 had a third arm that was nivo chemo, where would that fit in?
Yeah, that's a good question. I think when we look at the magnitude of the difference in benefit between these two trials, it would be hard for me to argue that cisgem nivo would beat EV pembro. So I think it would sit somewhere in the middle. So I think it is better than cisgem alone, but probably the results we've been seeing with EV pembro are really spectacular, and this treatment does not match that.
So I guess 3 months earlier, it would have been practice changing.
Yeah, well, I guess it
Maybe.
would, but I mean, at this point, it is registered in the US and in Europe. So EV pembro at this point is not registered in Europe yet, but we of course expect that soon. And I think what we have to keep in mind that maybe for the US, where EV pembro is now available to everybody, I guess, this is not the same in the rest of the world. So for some areas, EV pembro will not be available for quite some time, and this might be a nice alternative for patients, and is I guess also easier to administer because everybody knows both chemo and nivolumab generally. So this may still remain an option for some areas.
Just again, sort of theoretically, if someone didn't have access to enfortumab IO and did have access to chemo plus pembro or chemo plus atezo, would you be okay with that?
I think the trials that have been done were negative, and I cannot imagine a scenario where you would have access to chemo plus pembro or chemo plus atezo and not to chemo plus nivolumab. So basically, the question you're asking me is how confident you are that these checkpoint inhibitors are the same. I think overall the results for nivo and pembro have been most of the times across disease types very consistent. I think atezo generally has performed a little bit less so, so but that's still an unanswered question how much of a difference there is. I think the difference are not very large, but I think there's a slight difference between anti-PD-L1 and anti-PD-1, at least this anti-PD-L1.
Yeah, I mean, I hear people saying that outside of, bladder, so it's not the first time, although in a way, I don't know, can you think of sort of a biologic or translational reason why PD-L1 would be different than PD-1?
Well, besides hitting the PD-1, PD-L1 interaction, there's other interactions. So, for example, with PD-L2, which will be inhibited by anti-PD-1, I think. So these other interactions might be the difference. Then there's differences also in terms of antibodies. So that's not necessarily the target, but then the backbone of the drug can be different. So yeah, there will be some differences, but in terms of showing differences in efficacy, we'd need really large trials, and we just never have done those.
All right, please continue.
So these are the treatment-related AEs in this trial in the CheckMate 901, and basically we did not see any surprises here. So chemo-related toxicity is dominant, and of course in the chemo plus IO treatment arm, there's some immune-related AEs, and quite strikingly, in these 300 patients, we did not see any grade 5 immune-related events. We did see, I think, in both arms, one treatment-related grade 5 event related to chemotherapy. So then these two trials have now really changed the frontline setting, but a lot of patients unfortunately still progress eventually, and fortunately we have some new drugs that were also tested and even have gone through phase 3 trials and give new options for our patients. And one of those is erdafitinib. So FGFR mutations have been long recognized in bladder cancer. They occur especially in non-muscle invasive disease, in lower grade disease, but they also occur in advanced urothelial cancer at about 15%, maybe a bit higher. And this is mainly FGFR3 point mutations and fusions. And erdafitinib has shown is a selective inhibitor of FGFR, and it has shown good benefit in single-arm trials with response rate over 40% in mutated patients. So this trial had two cohorts. This is the most important one for now, 266 advanced urothelial cancer patients who had a mutation in FGFR3 or 2 and had previous treatment with at least checkpoint inhibition. And for most of the patients, also with platinum-based chemotherapy, were randomized to receive either erdafitinib, an oral drug, which is started at 8 milligrams per day and then pharmacodynamically adjusted, or chemotherapy, which consisted of investigator's choice docetaxel or vinflunine. And patients were treated until progression of the disease or unacceptable toxicity. And the primary endpoint of this study was overall survival. So let's first say that this has been a great achievement, because this is one of the first successful biomarker-driven phase 3 trials in urothelial cancer. And this trial was also positive for its primary endpoint of overall survival, showing benefit for erdafitinib with a hazard ratio of 0.64 and a p-value of 0.005, with a median OS for erdafitinib of 12.1 and chemotherapy of 7.8. Now, this trial also showed that erdafitinib had better progression-free survival and objective response than chemotherapy, with an objective response in about 45% of patients. So for this trial, for this treatment, I think life-threatening toxicity is very rare and is not really that much of a problem. However, this treatment does have a lot of low-grade toxicity that is pointed out here by arrows, which are common toxicity and which can really affect quality of life in patients as it is slowly accumulating over time. And I think this is one of the difficulties of treating patients with erdafitinib. And here again, dose reductions often have to be, dose adjustments often have to be made during treatment. And I think there is some data that this would not necessarily impact efficacy, or at least it's commonly done.
So just curious, first of all, in terms of your algorithm in patients eligible to receive erdafitinib, is this going to be generally second line after enfortumab pembro?
This is, you have to bear in mind that I'm in Europe and we don't have all these treatments necessarily available, unfortunately. So at this point, it's for us the chemotherapy followed by IO, and then in third line, actually EV is approved and reimbursed, and that's not the case for erdafitinib. So for us, EV is still the first choice, and then at about that time, I may do in fit patients do tumor sequencing and see if they could be eligible for erdafitinib. So for me, that's reserved as the last treatment. I think the very interesting question is indeed if EVP is your first line of therapy, would your next line in FGFR mutants be erdafitinib, or would it be something else? So I think at this point, given the long history of treating with chemotherapy, the most logical choice would be to give patients platinum-based chemotherapy if they haven't had it already, as after progression to EVP. However, the label does allow for erdafitinib, and it is an option in mutated patients. The trial was also eligibility was also written in a way that they would indeed. These patients would have been allowed. So patients who would have a checkpoint inhibitor were allowed in this trial. However, it was a very small group of patients. So I think this is not enough to really base a decision on. But then again, for chemotherapy, there's also not really any prospective data to show how it what the benefit is after EVP. So I think it's up to the investigator and patients, and it's also up to the toxicity profile, where, like I showed, oral erdafitinib, it sounds like it would be less toxic than chemotherapy, but it does have also quite a bit of toxicity, and you have to stay on drug for quite some time. So these are choices to make between a physician and the patient.
Yeah, that was actually going to be my next question, but I forgot the fact. Yeah, if you get EV pembro, you haven't had chemo, so you can give chemo second line. But can you talk a little bit more about, sort of life with erdafitinib, what you do preemptively, what kind of tolerability? The way you described it sounds like it wasn't that challenging, and yet I know oncologists, most of them never even used it, and it sort of seems a little bit, complicating with the different types of toxicity, the phosphate, et cetera. So how does that actually play out? What are, clinically?
Yeah, so I think phosphate is something to monitor. So this is an on-target effect of FGFR inhibition, and it's actually used in the beginning to titrate the drug. So if you're if you don't get hyperphosphatemia, you can increase to 9 milligram. If you do get hyperphosphatemia, you should go down in your dosing, and there's dose adjustment tables that are very clear on what to do. I think some of the other toxicities gradually accumulate, and for example, nail problems can accumulate, mucositis, some GI problems, skin problems, and most of these, this is also on target toxicity, and you usually have to dose adjust when this starts to become go towards grade 3, or when it becomes really bothersome to patients. So I think this is all the time a conversation with the patients. How much are you willing to tolerate, and when should we start to dose reduce? So it's not necessarily very complicated, but it's patients for obvious reasons, like to continue treatment. And sometimes you have to also protect them a bit for themselves.
So I was mentioning that bladder has become the poster child of IO ADC, but before that, for a couple of years, you were the poster child of ADCs to start with because you had two ADCs approved before everybody else started to get involved, and the other one was sacituzumab. So what's new with sacituzumab?
Yeah, so sacituzumab govitecan is used in several other cancer types, most notably breast cancer, where it is also approved. And this drug has also been tested in advanced urothelial cancer on patients who progressed after chemotherapy and checkpoint inhibitors. So basically the same position as where EV is now used in third line. This drug was first tested in single-arm trials, and that's where the registration is based on. And it showed very decent results. I say decent because we are now a bit spoiled with the results we've seen with EV, which is and erdafitinib, which is response rates over 40%. But 27% response rate is still clearly better than what we're used to with taxane chemotherapy. Now, the duration of response, as we see in the spider plot and in the number here, is also reasonable, and the median PFS in this study was 5.4 months. And this was the basis for the registration in the US by the FDA. It's not registered by the EMA yet, but a confirmatory study was also done. But before going into that, I would like to also show the toxicity, which is mostly hematological, and generally in other cancer types, and that's what most physicians, I guess, at least in the beginning, started doing here as well, is that G-CSF is only given in patients who need it. However, there have been some problems with neutropenia and neutropenic sepsis, potentially in patients who also have other toxicities that make them can have infections, for example, diarrhea and mucositis. And there have been some toxic deaths as a result of this. So generally, it's for patients with urothelial cancer, it's recommended to start G-CSF early. Now, the Tropics 04 trial is the confirmatory trial in which patients were randomized. So after chemotherapy and checkpoint inhibition, were randomized to receive either sacituzumab govitecan or investigator's choice chemotherapy. And this trial, there was a press release very recently, actually just before ASCO. And it read that the primary endpoint of OS was not met in this trial. And strikingly, the press release already mentioned that perhaps due to a higher number of deaths, treatment-related deaths in the SG arm related to neutropenic complications, could have contributed to this negative results. Now, we haven't seen the full data yet, but I think this is a clear warning sign, and it also shows that G-CSF should be recommended if still administering this treatment.
Yeah, it'll be interesting to see whether or not they actually got G-CSF. 'Cause I hear from breast cancer people, I think they generally use preemptive G-CSF. Is that what you're doing?
I think so. What I'm hearing from my breast cancer, so we're not giving this in standard practice in Europe. It's not approved, but what I hear from my breast cancer patients is that they do not necessarily always give G-CSF, and that they don't generally see this type of problem. But this is just from hearsay. I myself don't have much experience with this drug.
I mean, they have a lot of cytopenias. There's no doubt about that. But whether they see deaths or not, I don't think they do very much in terms of breast because they, pretty aggressive about preventing that. Also, we're actually doing a webinar on ADCs and breast cancer. I know they're all excited about IO plus ADC, and there's some sacituzumab IO studies going on there. Is that happening in bladder also?
Yeah, so there's something really interesting going on there. We see, of course, incredible results with EV Pembro. So EV plus IO for sacituzumab govitecan. Some of these studies have been done as well. It is, these are small studies in a different patient population, so generally second line or later. But they haven't been so far as striking as what we've seen with EV pembrolizumab. So this could be because of the line of treatment, but it could also be that the target, that the payload does matter, and that perhaps this payload is not as immunogenic as vedotin is. So these are really important questions going forward to investigate, I think, because this combination of sacituzumab govitecan with IO is also now tested in several trials in breast cancer, and some of the other topoisomerase payloads are also tested together with IO and breast cancer. So this is going to be a very important question for the years to come.
It's going to be really interesting to kind of see how that plays out. And, another thing I hear a lot about with ADCs, particularly in breast cancer, because they got some with HER2 positive disease also, is sequencing. Like ADC after ADC, do you want to change the target? Do you want to change the payload? Any thoughts about that discussion?
Yeah, that's again a very interesting question that we are only scratching the surface at this point. I mean, there's some sporadic reports of SG after EV, and I think there are still responses seen, but it's not fantastic. It's still very early. It could also, maybe these things change if there's another treatment in between. So if we now get EVP and you would get second line chemotherapy, maybe after that the ADC activity would still be there. These are things that we still have to find out, I think.
So you've got a pretty complicated algorithm already, and now it got a lot more interesting with the pan-tumor approval of TDXD. So let's talk about how that fits into this.
That's right, and this was, to me at least, very unexpected that this new approval. So this is based on the Destiny Pan-Tumor 02 study, a study of trastuzumab deruxtecan, or TDXD, and this is a drug that has been enormously successful in breast cancer, of course, showing enormous benefit, and also showing that even in patients with very low HER2, it could still be effective. So this is a trial where multiple advanced cancers were treated with this drug. All were HER2 IHC 2+ or 3+, and had at least one previous line of treatment. So for the bladder cancer cohort, I think there were about 40 patients, and primary endpoints of this study were objective response rate. And as we can see here in this graph, most of these cancer types, except pancreatic, did really well on this drug. So these patients were selected with IHC 2+, 3+ HER2, and had really promising response rates in this trial, and bladder did as well. So these are the PFS and OS curves for the bladder cancer patients. So there was not really a difference between IHC 2+ and IHC 3+. The objective response rate for urothelial cancer was 39%. So this looks all very very promising and good, and this is the data that the approval is based on. Now, one of the things that I think is very important to mention for people who are new to this drug, and all the breast cancer patients know this already, but this is a drug that can have a very serious life-threatening toxicity, which is pulmonary toxicity, interstitial lung disease usually. And this means that you have to be very careful monitoring your patients when starting this treatment. We also see in this trial that in all of the patients combined, the treatment-related grade 5 toxicity was 1.5%, and there was also 1% in the urothelial cancer cohort who died of pulmonary problems.
So just curious, if you had a patient with metastatic urothelial bladder cancer who'd run out of all the options that you just discussed, still had a good performance status, who had an IHC of 3+, if you could, would you offer the patient TDXD?
Yeah, I think if I would have this available, and if the patient is fit and still can have treatment, which is always an issue, of course, if you have had already multiple lines of treatments for advanced urothelial cancer. then I think this is a good option. I think ideally we would like to see a randomized trial, but I think we have to recognize here that the approval is not just based on 40 urothelial cancer patients. It's based on efficacy in a whole range of cancer types, and I think that makes the data more solid than it otherwise would have been.
As you said, the breast cancer people have had this out there for a while, and they've developed these sort of algorithmic approaches to deal with toxicity. They're very aggressive about antiemetic, initial therapy when the patient gets treated, and then very aggressive about screening for ILD, trying to diagnose it when it's grade 1. They don't retreat people who have symptoms grade 2, so they try to, they do scans like every as often as they can for a long time. Do you think that people outside of breast cancer are just going to sort of pick up those approaches?
I would hope so, because I don't see any reason why this would be different for our patients. So I think whatever the breast cancer people learned the hard way, we should definitely implement that when treating our patients.
Yeah, actually, we did a program at ASCO GU on bladder cancer. We had a HER2 section, and I actually showed video of a breast cancer person because I couldn't find many GU people who actually had that kind of experience. So yeah, I think that's what everybody's asking the breast people what they do. But as you say, the general oncologists, they know too.
Yeah, absolutely. Yeah.
All right. Well, let's. I think you have one
And
more
that's where we
slide
should
here.
learn from them.
Absolutely.
Okay, so this is our European guideline, actually the ESMO guideline, which we did an update at the beginning of this year to reflect all these new trials that have come out. So for us, the algorithm actually starts with the question: do we have EV pembrolizumab available? Because there's a few countries in Europe where it is available, but for many places it is not yet. So basically, all patients who are treatment naive and have advanced or metastatic urothelial cancer, in our view, if it's available, the first choice is EV plus pembrolizumab. And then after disease progression, there is the choice that we discussed before of platinum-based chemotherapy or potentially erdafitinib, if registered. And for areas where this treatment is not available, the choice is still based on cisplatin eligibility. So patients who are cisplatin ineligible should receive carboplatin-based chemotherapy and then go on to receive avelumab maintenance therapy if there's no disease progression, or pembrolizumab if there is disease progression. And for those patients who are cisplatin eligible, they basically have the choice to either start with cisgem plus nivolumab, or with cisgem and then give maintenance avelumab if there's no disease progression. And of course, after these treatment, there's all the new third line options and beyond. For Europe, the most important one is EV and potentially erdafitinib. So these are my conclusions for the developments in advanced urothelial cancer. Platinum chemotherapy has been the mainstay of treatment for decades, and many trials have tried to beat this but haven't succeeded. However, since last year's ESMO, there is cisgem nivo and EV plus pembrolizumab, who've both shown PFS and OS advantages. I think the magnitude of benefit is higher for EV plus pembrolizumab than for cisgem nivo, so I think that should be the first option. And there's now new therapeutic options besides EV, so erdafitinib in FGFR mutants, trastuzumab deruxtecan and HER2 IHC3+, and sacituzumab govitecan. However, their phase 3 trial has recently reported to be negative, so I think that's up for debate if you should still use this drug.